Good morning. Am I audible?
Yes, sir.
Shall we start? So today I will be covering retention and relapse. In this, I will be discussing with respect to definitions, schools of retention, courses of retention, and relapse, theories of retention, Riley Williams keys, types of retention, and the retentions. Coming to the introduction, teeth moved through bone using any orthodontic treatment have tendency to return to their original position. It means whenever we do any kind of tooth movement, it has tendency to return back due to periodontal pull. So it is necessary to give retention. The stabilization is required for the corrected tooth. Stabilization of the treatment results by retention is an integral part of the orthodontic treatment. It is recommended for all the orthodontic cases that retention has to be given at the end of the orthodontic treatment. Coming to the definition given by Moyers, retention is nothing but maintaining a newly moved teeth in position long enough to aid in stabilizing their correction. And relapse is defined as loss of any correction achieved by orthodontic treatment. So retention means maintaining its position for the long period of time is nothing but a retention, and the relapse is nothing but loss of any corrections which has been done by orthodontic treatment is called as relapse. Now question arises why retention is necessary. We can see in this there are many forces applying on the tooth surface, labial on the labial side, lips, upper lip and lower lip. There will be continuous force will be there on the upper incisors, and also from the tongue there will be labial movement of force on the upper incisor as well as lower incisors. Even after correction of orthodontic treatment, these forces will continue to be there on the tooth surface. So because of this, there may be chances of relapse. That's why once the tooth correction has been done, for example, the incisors are retroclined, they are proclined, then the force from the upper lip and lower lip increases on the labial surface of the tooth. To avoid this relapse, we need to give a retainer. Coming to causes of relapse. As I said, relapse is nothing but loss of corrections. Why does relapse takes place? So these are the etiological factors for relapse. Persistent etiology means it can be a thumb sucking, tongue thrusting, mouth breathing habit. It is also lead to relapse and erupting third molars. If after the correction of orthodontic treatment, if third molars are erupting stage, then it will push the first second molar and the first molar in the anterior regions. So this may cause lower incisor crowding or proclination of upper incisors. And continued growth. Due to continuous growth of the maxilla and the mandible, there will be a relapse of the corrected malocclusion. Muscle imbalance. As I said, if there is any open bite or deep bite cases or thumb sucking habits, this may also causes imbalance force on the upper incisors, due to which a relapse takes place. And one more is stretched periodontal fibers. Say for example, if any tooth is retracted or protracted, there will be a pull or push type of force in the periodontal ligament. This continuous force stretching of the periodontal fibers will cause relapse. And one more, the last, which is very important, is unstable occlusion. If the occlusion after the correction of orthodontic treatment, if they are not stable, if they are not in class 1 molar relation, if they are not in cusp fossa relations, then also relapse will take place. These are the factors which is responsible for the relapse of the malocclusion. Coming to the periodontal ligament traction, this is a theory which says that when any type of tooth movement takes place, there is a periodontal stretch. Due to this stretch of the periodontal fibers, will lead to relapse of the corrected tooth position. To prevent this relapse, we need to hold the tooth for another 4 to 5 months for the full time, or sometimes it may be holded for the 7 to 8 months. which means we have to give retainer for 8 months after the correction of malocclusion. So in this time, the stretched periodontal fibers will reorganize and adjust to the new environment, and thereby uh, we can reduce the relapse of the tooth. As I said, continuous growth. Due to due to continuous growth of the mandible as well as the maxilla, this may also causes a relapse. Relapse of the crowding, or it may sometimes may causes proclination of the upper incisors or the lower incisors. So that if any growing patient is there, there we need to give a long term retention with the help of retainers. Or sometimes you can give myofunctional appliances to hold the corrected malocclusion. The bone adaptation. Bone adaptation is also plays an very important role. When any kind of tooth movement takes place, what happens? The change in the bone morphology will lead to the relapse of the tooth. For that, to reorganize the bone, to increase the strength of the bone, we need to give retention for the long period of time, so that the bone will form, it becomes stiffer, so that it will prevent relapse. Muscular force. As I said, muscles is surrounded in the both in posterior and the anterior region, as well as labial and the lingual. From the labial side is a buccinator muscle and the lips, upper lip and lower lip, and the lingual side is tongue. Due to applying a continuous force on the both the side, this may also sometimes, if there is any imbalance between the force from the lip or from the tongue, it may also causes relapse. Persistent etiology. It means if any etiology is already existing in the patient, for example, thumb sucking habit, tongue twisting habit, this may also causes relapse of the corrected occlusion, which means we need to correct the persisting any etiology. Any habit has to be corrected first, then correction will be done, and any habit removing appliances should be given after correcting orthodontic treatment. And the role of third molar usually erupts at the age of 18 to 21 years of age. If orthodontic treatment is done before the 18 years, then the retention has to be given, or regular checkup should be done to see the proper eruption of the third molars, so that, or sometimes it may has to go for extraction to prevent the relapse of the upper and lower teeth. Role of occlusion. The good occlusion gives a very good retention, so that we have to maintain first to fossa relationship and class 1 molar relationship, which will prevent relapse and also give a stability of the occlusion. So that we need to see for centric relation, and the centric occlusion should be normal, that is 1.5 to 2 mm. In this range, the centric relation and centric occlusion should be there, so that it will hold the corrected occlusion. Coming to the schools of retention, there are different schools of authors has been said, in different philosophy has been given by different authors. They say these are the schools of retention. The first school says that occlusion school, which means the occlusion gives 100% of retention. If occlusion is normal, then it will give a retention. These are the authors who says that the occlusion plays an important role for retaining the corrected malocclusion. And another school of thoughts, this is that apical base school, which means the apical base, the bone surrounding the tooth surface, which gives more retention. If you give sufficient time to form the apical base, then it will give a more of retention. Next is the mandibular incisor school, which this school says that if proper positioning of the mandible is done, then it will give a less chances of relapse. And next is musculature school. According to this school, the musculature plays an important role for holding the corrected malocclusion. Coming to theories of retention, there are 10 theories which has been proposed by Riddles, and the 10th one is given by Moyers. Coming to the first theorem, this theory says that teeth that have been moved tend to return to their former position. It means any tooth which is moved from one place to another place, it is always have a tendency to come back to the original position. Any tooth which we have corrected, it is always have tendency to come back to original position. This is theorem 1. And theorem 2 is elimination of the cause of the malocclusion will prevent relapse. Elimination of any cause which is due to which a malocclusion has occurred, that cause has to be removed. Means etiology has to be removed, then we can prevent the relapse. Say for example, if patient is having a thumb sucking habit, in those cases there will be proclined upper incisors. If you ask patient to discontinue the thumb sucking or you can prevent the thumb sucking habit, then there will not be any chances of relapse. Coming to third theory, malocclusion should be overcorrected as a safety factor, which means the corrected malocclusion has to be overcorrected. Say for example, upper incisor, if they are retroclined, we need to procline them. We have to procline it little more, then the relapse will be less, which means the overcorrection has to be done so that even if it relapses, then it comes to the normal. And even in rotation cases, if we are done derotation of the tooth, we have to derotate it more. Excess derotation has to be done. Then even if it relapse also, it comes to the normal. Coming to fourth theorem, the proper occlusion is a potent factor in holding teeth in their corrected position. As I said, this theory says that the proper occlusion should give a proper retention. The occlusion has to be maintained. Here we have to see for centric relation, the centric occlusion should be normal and molar should be class 1 and normal OZ and OY. Theorem 5, which says that bone and adjacent tissues should be allowed time to reorganize around newly positioned teeth. We have to give sufficient time. Here, this theory says that we have to give sufficient time to reorganize the bone and the adjacent tissue. So that we need to give a retainer, or we need to we are supposed to we are not supposed to debond cases as early because we need to give more time to form the bone and the adjacent tissue. Coming to the sixth theorem, if lower incisors are placed upright on the basal bone, they are more likely to remain in good alignment. This says that if lower incisors are properly positioned, if they are upright, then there will be less chances of relapse. So we need to see that lower incisors should be well aligned and they are upright. Coming to seventh theorem, corrections carried out during periods of growth are less likely to relapse. This means if any treatment, if it is done, if the patient is in the stage of growing, say for example 15 years or 16 years, 14 years, in this age group the patient is still undergrowing. If after treatment is done, the patient who is in the growing stage, then there will be less chances of relapse. It means the corrected tooth will be stable for a long period of time. Coming to the eighth theorem, the farther the teeth have been moved, the lesser is the risk of relapse. It means the tooth corrections, if it is done and the more, the longer the tooth movement has to be done, the more will be the retention. Which means if any tooth is proclaimed over correction, it's a kind of over corrections. If we are done with more of corrections, then there is no less chances of relapse. Coming to ninth theorem, arch form, particularly in the mandibular arch, cannot be permanently altered by appliance therapy. Which means arch form. Say for example, mandibular, especially in the mandibular arch, the arch form should not be changed. If it is in any expansion or any buccal movement, it should not be overcorrected because there is more chances of a relapse. We should never do expansion in the mandibular arch, especially the mandibular arch. If you have done any expansion in the mandibular arch, there is more chances of relapse. So that we should take care the mandibular arch should not be expanded. If it is expanded, then there is more chances of relapse due to abduction intramuscular force. It will causes relapse of the dentition. Coming to the 10th theorem, which is given by Moyers, many treated malocclusions required permanent retaining device. This theory says that any treatment, any orthodontic treatment done in a patient has to be given a permanent retainers. According to this, every patient has to be given a permanent retainer. So according to this theorem, so we need to, but whenever we are giving any retainers, for example, removable or fixed, it has to be permanent. Patient has to wear it for long period of time. Next, coming to the Raleigh-Williams keys. These keys are given by Raleigh-Williams only for the lower incisor retention. As we have seen that lower incisors retention plays an important role for the retention. So that Raleigh-Williams has considered that it's very important to keep lower incisors in a proper position, which will help in the retaining the corrected malocclusion. So here we will see one by one incisal edges of the incisal edges of the lower incisors should be placed on the anterior posterior line or 1 mm in front of it. This is the point A and the point A, point P. If upper and lower incisors placed 1 mm anterior to this line, this will give more of retention, which means the incisal edge should be 1 mm ahead of this line. Second, lower incisor root should be diverging. When you see in the OPZ or lateral surf, you can or in an IOPA, you should these lower incisor roots has to be diverging. They should not be parallel. They should be diverging and they should be parallelly diverging. So these will give more of retention. And coming to third one, apex of the lower cuspid should be positioned distal to the crown. So the lower canine root apex should be distally diverging. It should be angulated in the distal direction. Next, fourth one, all lower, all four lower incisors apices must be in the same labiolingual plane. Means all lower incisors from canine to canine has to be in the same plane. That is they are same plane in the labiolingual direction. Next, lower incisor cuspid apex must be placed slightly buccal to the crown apex. It means the canine cusps and the apex should be slightly labial. That is slightly buccal to the uh, crown tip. And the lower incisors should be slenderized as needed after treatment. So it is in many cases if there is a crowding in the lower incisors, the slenderization, that is stripping or slicing of the incisors, should be done 0.5 to 2.5 to 0.5 mm on both the side, on the mesial and the distal side. This will give a more retention to the lower incisors. So these are the 6 keys of lower incisor retention. If we have to, after the correction of the crowding, we have to see for the inclination, root inclination, and lower incisor inclination, especially canine, and the lower incisor stripping. These things has to be done before deboning the case. Coming to the types of retainers, there are natural or no retention. There are in some cases where no retention is required. There are short-term or limited term of retention, prolonged or permanent retention. These are 3 types of retainers. In first case, no retention is required. In second case, the short-term retention is required. In third case, the permanent retention is required. We'll see one by one. Where are the cases there node retention is required, especially in the anterior crossbite, in case of serial extraction, or blocked out or heavily placed canines, and posterior crossbite. These are the conditions where retention is not required. It means even if you don't give any retainers, there will not be a chances of relapse. Next, short-term retention. It is in the cases of class 1 non-extraction, with the dental arch showing proclination or spacing, or in cases of deep bites, and class 1, class 2, given due to cases by the extraction. It means short term means it is from 8 months to 15 months, or in sometimes one to 1.5 years. So in these are the cases where simple cases like class 1 cases with non-extraction, or class 1, class 2 cases in extractions. These are the cases where we can give a short term retention. Coming to the permanent retention, in these cases, permanent retainer has to be given. Say, for example, in case of midline diastema, severe rotations, arch expansion, if it is done in the maxillary arch, and certain class 2 due to deep bite cases, patient exhibiting abnormal musculature or tongue habits. So these are the cases where we need to give a permanent type of retention. Especially in the severe rotation and diastema cases, we always give a fixed retainer. Coming to the retainers, types of retainer, it can be removable or fixed. Coming to the removable retainers, Bex retainer, clip-on retainer, wrap-around retainer, Kessling tooth positioners. Coming to the Hollis retainers, this is how the Hollis retainers looks like. This is short label bow or long label bow. Adams clasp on the both the side for the retention, and palatal acrylic. This is how Bex retainer looks like. This is a removable type of retainers. Encircling from the last molar to from molar to molar, a single wire, and the acrylic plate. And next one is clip-on retainer. This is how clip-on retainer looks like. This is a stainless steel framework with acrylic on the lingual side. And next is a aligner. This is also called as Kessling tooth positioners. This is a transparent acrylic plate. This is removable one. This is how it looks like. Coming to the fixed retainers, the wire and the bracket also plays an important role. It can be used as a fixed retainer. Sometimes we should not debond the cases for the long period of time, so that it will act as a retainer. And there are banded canine to canine retainer. This is a preformed retainer which can be bonded on the both the side on the canines, and this is a horizontal arm. This is a bonded type of lingual retainer. This is given from canine to canine or sometimes premolar to premolar, especially in case of first premolar extraction. To place a ligature wire and bond each tooth with the help of composite. Next one is band and spur retainers. We need to band the canines on the both the side, and the stainless steel wire will be welded on the canines both the side, and it should be cemented. This is how it looks like, band and spur retainer. And this completes different types of retainers, removable and the fixed. The retainer has to be selected depending upon the type of the case, type of the malocclusion. Thank you. Any doubts?
No, sir.
So you read it once again from the textbook. If you have any doubts, you can ask me anytime. Okay?